Okay, everybody, we're going to get started. It's my pleasure to introduce Dr. Carol Saunders. She's from Children's Mercy Genetics Laboratory in Kansas City, Missouri. She received her PhD from the University of Kansas, Department of Molecular Biosciences. She's currently Clinical Director of the Center for Pediatric Genomic Medicine at Children's Mercy Hospital, Director of the Molecular Genetics and Diagnostic Lab at Children's Mercy, and Associate Professor of Pediatric Pathology, Adjunct Associate Professor of Microbiology in the Department of Biochemistry, and Assistant Professor in Pathology and Laboratory Medicine. So we'd like to welcome her and thank her for coming.
Thank you for that introduction and the opportunity to be here today. Okay. So today I'll be talking about some efforts underway at our hospital to try to diagnose patients who were previously basically undiagnosable, and I realize that's probably not a real word, but that's okay. And if you're not familiar where we are, find the pointer. We are in the middle of the country. We straddle Kansas and Missouri, but we're actually on the Missouri side, and we are famous for fountains and barbecue and jazz. And on the Kansas side, you cannot escape the Dorothy jokes that I've had my entire life. This audience is well aware that there are many, many genetic diseases, probably about 8,000 we think, and these are collectively a major source of morbidity and mortality for our children. So they affect 1 in 33 children, which in Missouri it translates to about 1,800 Missouri newborns each year. They result in 1 out of 6 hospitalizations and 1 out of 5 deaths out of the 60,000 babies that are born in Missouri each year. So out of those 8,000, the genetic etiology, or being able to pinpoint a specific gene to those diseases, that only about half of them are currently known. So for these families, the diagnosis takes sometimes years, as one of the last speakers pointed out, if it happens at all. Getting a diagnosis, if you're that family, it's kind of an emergency, especially if the baby's, in an acute care setting like the NICU. And then any kind of delayed diagnosis is going to delay potential treatments if they exist, and services for the family. And so most genetic testing, as everybody knows, takes weeks or even months to get back, and so that is much too slow to drive any sort of care or management of the patient in an acute care setting. So I'm mainly going to talk about our efforts directed at the NICU patients, but I'm going to tell you just briefly about the other testing we have going at the Center for Pediatric Genomic Medicine. We have one test called TAG-SCAN, which is clinically available. It's a targeted test that targets 540 genes plus the mitochondrial genome at a high coverage. This is driven, the analysis of this is driven by the patient's symptoms. So we standardize the patient's symptoms using a medical vocabulary like SNOMED or HPO terms, and then this drives the analysis of which genes get selected for that patient. And then we also do exome sequencing, which is currently only on a research basis. So that's targeting the 22,000 genes in the genome, and we're targeting every exon, but everyone knows that exome sequencing isn't perfect. You sometimes have regions that are GC-rich that drop out. But it's still good for the diagnosis of heterogeneous disorders and your medical mysteries, and also for discovering novel disease genes. And then the last one, or not the last one, but the one I'll mainly focus on is StatSeq, what we call StatSeq, which is our rapid genome sequencing project in the NICU, which is offered under a research protocol. So it's reserved for our NICU and PICU cases where we think that a fast diagnosis could potentially change the treatment or outcome of the patient. And just recently, we've begun doing RNA-seq, so it's looking at the transcriptome, which we hope will be a good functional adjunct to genome and exome sequencing. And we just developed a pipeline for analysis of that, and we're currently kind of investigating the use of that. So the whole genome sequence that we do, again, it's just under a research protocol right now. We're lucky to be part of the NIH Insight Award program. So one of the last speakers said something about a crocodile budget and a canary or something. I'm going to remember that one. But we are fortunate right now to have a crocodile budget to do this study. But the parents, of course, have to consent to this, and sometimes I think if the baby is 2 weeks old or less, both parents have to consent, and sometimes both parents aren't available. And so we've had some issues, with social issues, being able to consent people who really do want to participate. And then, of course, since this is all done under research, in order to make it into the medical record for the patient, we need to do some Sanger sequencing, some custom Sanger sequencing before we issue an official clinical report. So this just tells a little bit about the Insight program. It's just to explore the use of genomic information to understand genetic diseases that affect newborns. So people are involved in this program are either looking at how to use genome sequencing for newborn screening, to screen for what we're currently screening, or to use it to supplement what we're not currently screening for, or to look at what additional information can we glean from for whole genome sequencing. So you have to have 3 components of this. You have to have genome sequencing, clinical research, and then there's an ethical piece that looks at the ethics and the social implications of this. And then there's four groups that are involved in this. We're one of them. There's UNC Chapel Hill, UC SF, and Brigham and Women's. So the way this all works, the stat genome business, is that we have embedded in the NICU, we have 2 people. We have a neonatologist and a nurse research coordinator who works on our team, and they work to select patients who may be appropriate for the study. Those patients are reviewed by a small team of us who decide whether they're good candidates. They obtain parental consent if the parents are interested. We get the DNA sample. And the first step in the process is, on the first day here, is the library prep and the QC, and that takes about 4 hours. And while that's being done, there's somebody analyzing the medical record and generating what we call HPO terms, which is a standard vocabulary, standard medical vocabulary that we use. And it's available, it's the Phenomizer tool that's available online. So that all takes about 4 hours. And then the sequencing is put on, we use the HiSeq 2500 in rapid mode, and that sequencing step takes about 25 hours. The bioinformatics takes another day using our standard pipeline, but we're also using something called Isaac from Illumina, which only takes about 2.5 hours. So we're planning to use those in parallel because we think our runes pipeline is a little bit more sensitive than Isaac, but we're still looking at that. And then the interpretation at this point is available. And in our experience, if there is a diagnostic genotype to be found, this step really doesn't add that much more time to get the diagnosis. If you're going to find something, I think it's going to be within 5 or 10 minutes. If you don't find it within 5 or 10 minutes, I think the odds go way down that you're going to find anything. And then there's an additional 4 to 5 days for the Sanger confirmation and the clinical report. So that time is going to depend, if it happens to be a gene for which we already have Sanger primers in the lab, then it would take some time off of that. We've had several cases where we did have primers already in the lab, and so it only adds a couple days, but usually it's a better part of a week. And you might be thinking, where do incidental findings play a role, in all this? And right now, we are not reporting incidental findings. I think we need to revisit our protocol, which was made way before, our repository protocol was generated way before all those ACMG guidelines came out, and I think it's a discussion that we need to have again at our institution. Okay, so out of a whole genome, you have 3.2 billion base pairs. In the average Caucasian sample that we sequence, you get about 5 million variants to look at. But we're really not going to look at all of those because the analysis is going to be largely confined to the coding region and the splice junctions of the genome, because that's really all you can hope to interpret at this point anyway. So really, you're doing a genome because they're faster. There's no enrichment step, which is one reason why we do it. I also like genomes because whereas exomes, you have all the problems with GC-rich regions dropping out, or just specific regions dropping out for coverage. Genome sequencing, it's going to be lower coverage overall, but it's very even. You don't have that same problem, so I don't think we miss as much about having gaps in coverage. So you're going to apply a frequency filter, and most of these things are going to be so rare that you want to look at variants that are only 1% or less minor allele frequency in the general population. I would go a step further and say in our database of, I think we've sequenced, well, I'll tell you how many families we've done genome sequencing on, but exomes all included, I'd say we've done about 2,500, so we have a good database of variants. And probably about 50 to 75 million variants. And so it becomes a really powerful tool to know that a certain variant that you found has never been seen in your own database. So the first filter I apply is I look for family-specific variants in our database. And if you don't find something there, then you can expand it further. But that's a good place to start. So that gets you down to about 1,500 variants if you filter out the common stuff, you filter out all the introns and regulatory sequence, and then if you apply a further filter for phenotypically relevant genes using those HPO terms that somebody put in at the beginning, then you're probably down to just not that very many candidates. So, and hopefully at the end of all that you have a clear diagnosis, but obviously not always. So we've been doing this now for a couple of years, and the question is always, what are we finding, and does it make any difference? And I will say yes. So I hope to illustrate all these points that it's a way that we can rapidly diagnose critically ill patients and end the diagnostic odyssey for the family. We can identify treatable conditions earlier, and I think people underestimate the things that are treatable or have some sort of management change to them. And then there's sometimes a quicker path home for the patient, whether that's through palliative care or home, just being released from the NICU. And in most cases, these actually all the cases, these three things apply. And I'll tell you about some other cases. But the first case I'll present is CMH 487. And this is a baby who had maternal screening at 16 weeks that revealed an elevated AFP. So they did a fetal MRI, which identified an omphalocele and some potential scoliosis and other anomalies. And the mom had gestational diabetes that was treated at 30 weeks. The baby, we have a kind of a unique setup where if you have a high-risk pregnancy, there's an OB unit within our children's hospital. So the mom can deliver the baby in the hospital. The baby can be transferred right to the NICU, and the mom can be staying in the same facility. So it's not, hopefully not as stressful as it could be. So this baby was admitted to our NICU for treatment of a ruptured omphalocele. He was examined by the geneticist who identified subtle dysmorphic features. He was large for gestational age. He had scoliosis and some other anomalies. And so some testing that they did was for Beckwith-Wiedemann syndrome, in addition to karyotype and microarray, all of which were normal. So he was in the NICU for a couple months, and his omphalocele is tented and healing, and that's why he's there. And then he experienced a sudden elevation in liver enzymes that was unexplained. And at that point, they really just wanted to know, why is he having liver failure? They had counseled the mother on several occasions that they really were not sure that he was going to make it. So it was a pretty acute situation. So the family was enrolled in StatSeq. So this is just an example. I don't know if you can read this very well, but it's an example of the input of the baby's symptoms into the phenomizer, or the HPO terms that are used. So in this case, I can't read it down here, but it's the emphalasy, thrombocytopenia, liver function, that's all entered in there. And then in this case, you come out with 254 matching diseases that the system puts in for you. And you can see at the top a lot of the main differential is for congenital disorders of glycosylation. And this screenshot shows, this is a screenshot of our analysis tool, which we call Viking, which is just an acronym for variant integration and knowledge interpretation in genomes. So this is a program that allows us to integrate the input of the phenotypic features of the patient along with all of the variants that are found in the genome. It allows you to sort dynamically. It allows you to filter different things by either symptom or by frequency filter, taking out all the common variants. So here it's identified a variant. It's a rare missense variant in PRF1, which is associated with familial hemophagocytic lymphohistiocytosis. And it's the only time I will say that. So this is a very rare variant. It's the only time it's been seen in our database, but there's only one that meets those filtering criteria that I set. So after you broaden the screen a little bit, and you see there's a second common variant in the same gene. It's an alanine 91 to a valine. And this is actually really common. It's so common you want to dismiss it because it's in 7% of the general population. But when you look at the literature, there's actually a lot of good functional evidence that this is a strong susceptibility factor for HLH if it's in the presence of a second pathogenic mutation. So then the question is this one missense variant that we have, is this a pathogenic mutation? And so a lot of times when you're doing this, you get stuck. It's like you've got a fairly compelling genotype that could explain something for the patient, but you can't really call it anything other than a variant of unknown significance. So what we do in these cases is sometimes you phone a friend. So we consulted with the good folks at Cincinnati Children's who have been testing for this condition for a long time and have a lot of experience with it, and just asked, have you seen this variant? And in fact, they had seen it previously in several people with HLH and their relatives, but only those people. So it was very limited to people affected with HLH or their relatives. So they thought it was highly suspicious and encouraged us to do functional testing for HLH, which includes perforin expression and NK function studies, which we did. And the perforin expression was reduced and the NK cell function was absent. And the clinicians initially were really skeptical because his presentation really wasn't typical for HLH. If you look at the diagnostic criteria, I think you have to have 5 things checked off of this list. So he did not have the typical fever or the rash that you might expect. He had only modest splenomegaly, and only after this functional studies for the decreased or absent natural killer cells, that was done only after the molecular. So they were a little skeptical, especially I think as geneticists you tend to be lumpers. You want to find a unifying cause for all the symptoms, even though you know that the patient can have more than one thing. But I think people were assuming that all of his features were related. And so anyway, they gave steroids and IVIG, and he rapidly improved, and his liver function returned to normal, and he was able to be discharged, and he's followed by the PAC team, or palliative care people. So I like this case because it really illustrates a lot of things that we encounter. It's the potential of having confounding symptoms where, really you have multiple diagnoses present in the patient. And I think his other features could be attributable to a de novo variant that he has a lysine-specific demethylase. It's just an interesting candidate gene at this point. It's not a known disease gene, but it could be interesting. And then there's the potential problem in filtering out the common variants, so we could have missed that other variant if someone hadn't been paying attention. And then there's a reliance on other people who have more experience with the gene that you're looking at, because it's impossible to be an expert on every single gene in the genome, so it's really nice to have collaborative people who will help you out. And then it's really nice if there's a clear functional test to be done to to correlate with your findings. Okay, so the next case I'll talk about is another one that illustrates just getting the diagnosis quicker, getting the treatment quicker, and getting out of the NICU quicker. So this is a baby who had a history of hypoglycemia since birth when her glucose level was found to be only 18. She didn't make it to our institution until 4 weeks of age, where she was admitted with a glucose of 29, and it remained just dangerously low even after feedings and after really aggressive medical management. She was on the maximum dose of diazoxide. She was the fourth child born to her parents, and nobody had similar concerns in the family. She passed her newborn screening, and so she was enrolled in StatSeq for this reason. And I'm just kind of giving you the timeline of how things went for this case. So on a Wednesday, the endocrinologist was consulting with the congenital hyperinsulinism team at CHOP about potentially transferring this patient to their care for surgery. And it wasn't clear which kind of surgery it would be, but the endocrinologist made some statement that we are going to have the genetic results in hand with this patient when she's going to CHOP. And somebody actually called back and he said, oh, you can't do it that fast. Just, you can transfer her anyway. And, he said that's just not possible, but we were able to do it. So she was consented, or the family was consented on a Wednesday. They received samples on a Thursday. We did the sequencing over a weekend, and were able to discuss a preliminary result with the endocrinologist on Sunday night. We did the confirmatory testing. The diagnostic report was signed in the medical record, and she was flown to CHOP on Monday with the results in hand. And as you know, the turnaround time for a clinical lab performing sequencing, and in this case it's for the ABCC8 gene, is usually about 4 to 6 weeks. So she was found to be heterozygous for a known pathogenic ABCC8 variant. It's a missense variant. It has a lot of good functional studies out there to show that it's actually a pathogenic variant. But there's no second variant. And ABCC8-related congenital hyperinsulinism is a recessive disease, except when it's not. It's one of these fun things where you can have dominant inheritance with reduced penetrance, but only if it's paternally inherited. And in that case, your odds of developing this condition, if you have a paternally inherited mutation, is about 1 in 570. So she is 1 out of 570. So she has a presumed second hit. It's a somatic event in a subset of the beta cells of her pancreas that have loss of the maternal copy, whether it's through UPD or a second mutation or what, we haven't investigated that. So if you have paternal inheritance of a pathogenic ABCC8 mutation, it's highly suspicious for the focal type of disease, what's called the focal type of disease versus diffuse disease. And there's a drastically different treatment and outcome for this. So for the diffuse disease, where you're inheriting mutations from each parent and every cell is going to be affected, the treatment is a complete, or a 98% pancreatectomy. And that will cure your congenital hyperinsulinism, but it will leave you with lifelong diabetes. In her case, she has focal disease, so only 40% of her pancreas was affected, and so the treatment is a resection of that part of the pancreas, and she's completely cured. And she doesn't even have to be followed by endocrinology anymore. She's passed whatever tests that they do for her. So in that case, it's just a quicker path out of the NICU. It's getting the right treatment. This next case it illustrates getting accurate prognostic information and recurrence risk for the family. So this case is an 8-week-old former term infant who was spontaneously vaginal birth, admitted for failure to thrive, and she was weighing only 7.7 pounds at the age of 2 months. So when she was admitted, she was found to also have lactic acidemia, hypoglycemia, and hypotonia. And so she was the first pregnancy between, and you can see her growth curves here. This is her weight, and this is her height. So she was the first pregnancy between her parents, but her maternal half-brother had some feeding difficulties also in the newborn period. So if you look at the differential for this, which is lactic acidemia with hypoglycemia, less than robust ketosis in a hypotonic baby, it's pretty nasty. You think about respiratory chain defects. You think about pyruvate dehydrogenase complex deficiency, and this was thought to be her most likely diagnosis. Also pyruvate carboxylase deficiency. And so the baby was started on a modified ketogenic diet and enrolled in StatSeq. And what we found was a homoplasmic mitochondrial variant in both the mom and the daughter. You can see here, so this is the next-gen reads looking at, here it's a T to C. And so this is a drastically different prognosis than what anybody thought. So this is associated with reversible cytochrome C oxidase deficiency. And when we first saw this in the literature, kind of thought it's like one of those, I don't know, but this is a maternally inherited condition with variable penetrance. Which is why, in the world of StatSeq at our hospital, there's StatSeq where it's the instantaneous diagnosis, and then there's this, which was like maybe a couple weeks later after, it was initially missed because of just the situation. And also, there's a problem. You have to realize the limitations of your own pipeline. So our pipeline relies on HGMD to tell us whether a variant has been flagged as pathogenic or not, and HGMD does not include mitochondrial variants. So we're still manually curating mitochondrial variants, but so that's why it wasn't flagged as a known disease mutation, and the inheritance pattern was a little, suspect. So it wasn't until a more senior person looked at this case, and when I say senior, I don't mean age, I mean experience. Anyway, so this condition, as the name implies, the patient will spontaneously recover if they make it through neonatal period, which requires really intensive therapy to manage the nutrition issues and the breathing issues. So a lot of times they end up intubated and with a G-tube. So even though it's initially life-threatening, it's ultimately reversible to the most part. Some patients will develop kind of a myopathy later in life, but a mild myopathy. It's not the fatal kind of nasty conditions we were talking about. So this diagnosis was also important for the baby because since she was on the modified ketogenic diet, she couldn't learn, she was having difficulties learning to swallow herself because of her, just her condition. And so with a ketogenic diet, they couldn't use thickeners for her milk or formula. So after this diagnosis, they took her off the ketogenic diet, which would allow her to be able to, learn to eat, which is important. Okay, and then this next case I'm going to illustrate a condition which resulted in a new trial, like a clinical trial. We call them N of 1 clinical trials because she's on her own personal clinical trial. So this is a baby who's 6 months old who was admitted to our PICU for hypotonia and ptosis, which she had had since birth. They thought she had congenital myasthenia gravis, but she tested negative for that condition. So she developed respiratory distress, and she coded in the PICU, which was a convenient place for that to happen if it's going to happen. But so she was enrolled in StatSeq for that reason, and we did rapid genome sequencing revealing compound heterozygosity for variants in the SLC25A1 gene. So this is a gene that encodes the mitochondrial citrate malate transporter. And not very many people have been reported with this. I think last we looked, there was about 13 patients in the world. And out of those, 8 of them died before 7.5 months of age. So it's pretty uniformly lethal. And she was pretty suspicious to have this. She had 2 missense variants, one of which had been previously reported in the homozygous state in a patient with confirmed combined D2L2 hydroxyglutaric aciduria, which is what this gene associates with. And again, just looking at our database, this is the only time that we've seen these variants is in this family, and so the patient is compound heterozygous. Each parent carries one of them. So this happened actually on Christmas Eve, I think. I was texting the biochemist, like the metabolic geneticist on call, and yeah, he was initially not very impressed because her urine organic acid profile was not all that clearly diagnostic. Like, her levels of 2-hydroxyglutaric acid were a little mildly elevated, but it wasn't that impressive. And so I asked him if he would repeat them, and he said, well, I would call this one normal, and so, if we repeat it, I'm going to probably call it normal again. But they did repeat it, and it was still around the same range, but we began correspondence with a research lab in Europe who is the primary people who work on this condition, and they told us that these levels can be very low, but they're expected to increase over time, and they encouraged a couple other tests to do, which would kind of go along with the condition. So one is looking at the D2 and L2 hydroxyglutaric acid enantiomers, which we did, and were elevated. So we started her on citrate around, I think it was about a month or 2 after that. We kind of developed a discrete protocol for her where she's given, I don't know what the dose is, but she's giving polycitra daily. And we are measuring, I think, monthly or every 2 months, the levels of citrate, 2-hydroxyglutaric acid, and malate. So initially, this is about the time that citrate was started, and these are the levels of 2-hydroxyglutaric aciduria in blue. So they began to decrease, and you can see now at her last reading, they're increasing again, and the metabolic geneticist thinks that that's because the family is not bringing her in as often as recommended, so she's probably not being dosed for her current weight. So that'll be interesting to see over time. But if you look at her clinically, she's actually improving. She has developed some seizures, but they're not the severe apneic events that other patients with this condition have. Her tone has improved, and her ptosis is improving. So it's encouraging, but it remains to be seen what will happen. And then the last case I'll illustrate just discovering a new disease gene, which we've done a lot with exome testing, but a few cases also with StatSeq. So this is CMH183. This was a male baby who was born with multiple cardiac anomalies. You can see probably better than I can here. And he also has thoracic situs inversus with reverse position of his spleen, liver, and stomach, descending aorta, and inferior vena cava. So his family history is significant for having a brother who looks pretty much just like him, an older brother. They are Hispanic, non-consanguineous family, and there's 2 other siblings who are unaffected and alive and well. And the genetic counselor just called me last week that the mom showed up to the prenatal clinic asking for prenatal testing because she's pregnant. So when this baby was examined, he was found to be non-dysmorphic, but he was large for gestational age, and the mom had gestational diabetes. So it was thought that some or all of his symptoms could be attributed to that, although the family history suggested possible X-linked etiology. So ZIC3 is one gene that's associated with heterotaxy, and it's X-linked, so that sequencing was done clinically. A karyotype was normal, and a microarray was done, which revealed a 634 base pair interstitial duplication of XQ26. And this was actually found in the mom and the affected brother. We requested testing of the 2 other siblings, but we have not been able to get samples for them for the microarray follow-up or for the whole genome sequencing follow-up, and it's not for lack of trying. So the Q26 duplication has been reported in conjunction with, I think it's a couple of boys with mental retardation and some other findings, but no mention of any cardiac disease. Our patient's duplication was actually affecting exons 8 and 9 of the a gene that's associated with Simpson-Galabi-Belmo syndrome, which he does not have. So we thought it's unlikely this microarray is relevant to this this family. So they were enrolled in StatSeq, and initially we thought BCL9L was a really good candidate for this family. He had compound heterozygous mutations that were shared, the genotype was shared by the affected brother, both parents were carriers, that they were both rare missense mutations specific to this family. The gene is involved in Wnt signaling, and all the other genes in this pathway have animal models that go with heterotaxy and all this kind of stuff. So we thought it was a really good candidate gene, but there were no functional studies available. So that was that was a while ago. That was probably a couple years ago even. And in the meantime, we've been working on a way to look at deletions in whole genomes, and we had a medical student who came through and wanted a master's project with us. And he happened to be a bioinformatician. So he developed a bioinformatic pipeline to look at deletions in whole genome sequencing. So after he ran his program, we went back and looked at cases where we didn't really feel like we had a clear-cut, satisfactory diagnosis, and this was one of them. And they found that there was an MMP21 gene deletion that affected the first 3 exons in the proband, the sibling, and the mom. You can see here, if you look in IGV, I don't know if you can see, here's coverage for a whole genome, and then you can see here just a rapid drop or a dramatic drop in coverage here that outlines exons 1, 2, 3 of this gene. And then when you go back and you look for a second mutation, you see a frameshift mutation in this gene that's found in the father, the proband, and the brother. And that's shown here. And this frameshift occurs in exon 2 of the gene. And then if you look in there is no papers out there in PubMed, but if you look in the Jackson Mouse Lab site, there's a report of a group that has made mouse knockout of this, and the mouse has transposition of the great arteries and abdominal situs inversus. So we called this investigator, she's from the University of Pittsburgh, and she has not only a mouse, but a zebrafish who looks just like our patient. And we were excited maybe she would want to publish this all together, and she has some giant mouse screen going that she plans to submit to Nature. So we're waiting for that to happen before we can do anything with ours. So just some quick stats on StatSeq to summarize. So far we've run 34 families. These are mostly trios, so if you multiply by 3, that's about the number of genomes that we've done, although we've missed probably a dad here and there, maybe even a parent here and there. So we've made a diagnosis in 20 of these cases, so that's 56%. On any given week, this might go up or down a little bit, but it always stays within 50 to 60%, which is kind of surprising. And out of the 20 positives that we had, what's even more surprising is that 11 of these have de novo variants, which is really high, I think. So there's some repeat offenders. One of them is the PTPN11 gene, so there were 3 of those. And these are not your typical Noonan-looking babies in the NICU. 2 of them did have hypertrophic cardiomyopathy, but otherwise didn't necessarily look that Noonan-y. And then one had chylothorax, which is a rare presentation for PTPN11 related disorders. But if you look at the actual variant that these patients have, they all have different variants, but they're all Leopard syndrome variants versus Noonan syndrome variants. And so that's another potential avenue for N-of-1 clinical trials. If we have a patient who has severe enough cardiac disease, then there are some mTOR inhibitors like rapamycin that can target this pathway, whereas Noonan syndrome mutations are our gain of function, leopard syndrome, our loss of function, and this particular strategy could work. It works in the mouse anyway. There's no studies yet in humans that I'm aware of. We've also had 2 de novo SCN2A variants out of this small number of people. And so in addition, we have 4 that have interesting novel candidate genes. I told you about a couple. And we have one additional patient in whom we've identified a deletion with the new deletion pipeline we're trying. This is a 1p36 deletion that was confirmed by cytogenetics. And I didn't count that in our positive statistics because we really didn't find it that way. And then this is all the positive findings to date, if you're interested, just what other genes we're seeing. We had a baby who basically had, and this was published in our 2012 paper, a baby who had GJB2 related, what looks like EB. We've had a really rare neonatal epilepsy gene called BRAT1. We've had, what else? Some of these changed management, like we have one with RYR1 related myopathy, so there's anesthesia concerns there. What else? Our most recent ones are, we had a baby who had very little respiratory effort at birth and was dysmorphic and had seizures, and we found a frame shift in the FOX2B gene. This was just a couple weeks ago. This was also de novo dominant. And just last week, as far as I know, we're still confirming it. I don't know if it's been finalized, but we have a patient with neonatal diabetes, hypoplastic right heart, and biliary atresia, and we found a GATA6 mutation, and I think it's a frame shift, and so that is associated with pancreatic agenesis and neonatal diabetes related to that, as well as some other things that they weren't necessarily looking for. So we were able to give a preliminary report since we did feel like it could change management with the addition of pancreatic enzymes. So I feel, just in summary, we're moving from traditional medicine where we're looking at what we could look at, because that's the only place we could look, to genomic medicine where we're finding really rare things that would have otherwise probably not been considered or even looked for because they didn't exist as disease genes until recently. So this is very much a big team effort. Our boss, Stephen Kingsmore, is the director of the center. He's here. And we have a big team of bioinformaticians and interpretive staff and laboratory staff and collaborators who are very helpful, and generous support from the NIH and a lot of private foundations that we're happy to have. So thanks for your attention. Take any questions?
How does this compare to your, if you did a head-to-head between this and, say, exome sequencing, do you think you would pick up the same variants that you picked up in the 30 families, or?
We need to look at that because we're actually also doing exomes in all these cases too, and I haven't gone back to see what are we missing or not. My feeling is not that much. I think the reason we do it is mostly for being able to skip the enrichment step. There probably are a couple that we would have missed by exomes, but we don't know yet.
So at least it's faster than to do.
It is faster.
Whole genome.
And if you look, we haven't looked at the hit rate for all of the different exome cases, but for a subset of cases, like for neurodevelopmental disorders, our diagnostic rate is about slightly over 40%. So this is much higher than what we see for exomes anyway.
And then how much 5-hour energy do you drink, or how much sleep do you get?
It's just Diet Coke.
Diet Coke, okay.
Yeah.
Yeah, Carol, that was my question, is how much just of your time does this project just consume everything, or do you guys share work and then sort of come back together, just knowing sort of the metabolic world, how we work on stat cases? I mean, it takes a coordination of a lot of different groups to get this done this fast.
Yeah. we're kind of working on our protocol for that, since this is all going to get ramped up, and the numbers kind of make me want to just go twitch in a corner a little bit, really. But we have a process where we're assigning 2 analysts per case. One is the primary, one is the secondary, and they have so long, the primary has so long before they say, okay, I don't see anything, the secondary takes over. There's varying degrees of experience on our team, and backgrounds. And let's say there's maybe a more senior person who is not that much older, who feels like they need to look at everything too. So I try to look at all of them, but it might not be I can't look at everything in real time, but I sometimes go back. But, we need to add more people to our team for sure.